My name is Rachel Blankstein-Bremen. I'm an assistant professor at the University of Maryland School of Nursing. And it is an absolute honor and privilege to introduce Dr. Nadine M. Finigan-Carr. She is a prevention research scientist focused on the application of behavioral and social science perspectives to research on contemporary health problems, especially those that disproportionately affect people of color. She is an internationally recognized expert on minor human trafficking, sexual exploitation, and community violence. Recently, she was named the inaugural executive director of the University of Maryland, Baltimore Center for Violence Prevention. The center's mission is to build resilient and equitable communities for all through the prevention and intervention of all forms of violence and trauma. And I hope that I get a chance to work with her, since we are in silos at the university, at the School of Nursing and School of Social Work. And without further ado, Dr. Nadine Finigan-Carr.
Hello, everyone. So I get the distinct pleasure of speaking to you after you've eaten. I want to know who scheduled this. So as you heard, I am Dr. Nadine Finigan-Carr, Executive Director of the Center for Violence Prevention at UMB. Just in terms of a little bit of, especially for those who are watching or listening, I tend to explain some things because you never know when people have a disability. So as a result, who stands before you? I am a light-skinned Black woman. I have dreadlocks. I have a slight accent that's a mix of New Yorker and Caribbean native, primarily Trinidad and Tobago. So there's a trend here today. And so my talk is specifically called Battling While Birthing, because you are probably wondering, why is the executive director of a Center for Violence Prevention talking at a maternal mortality conference? And that's because issues of violence really impact maternal mortality in ways that some of us don't even think about. Some of them are obvious, and some of them we don't think about first and foremost. And one of the things, I'm going to jump onto it now, even before I get to the who's at the table part of my talk. I noticed that people were passing around and talking about this Maryland Mom resource guide, right? That's amazing, 2,500 people. Guess who's missing? There are no, I looked, I was like, where's the intimate partner violence people? Where are the community violence people? Why are we not included in this list of people that support moms during the perinatal, antenatal, postpartum period? We need to be there too. So looking forward to really sharing with you over the next few moments my work and then how it impacts you. And then now I'm going to put on my glasses because I'm not going to pretend that I can read my notes without them. So, all right. So which direction does, oh, perfect. All right. So I'm not going to read the objectives directly, but by the end of my time today, if you learn nothing else, you're going to have an understanding of violence as a driver for maternal mortality across the board, and specifically how it manifests here in Baltimore City. So, okay, there's a combination of the lighting, the glasses. Let's see how this works. Oh no, I'm going to need these. All right. So what's community violence, right? So community violence may actually be a very important mechanism through which historical patterns of segregation and economic exclusion influence health outcomes and health disparities. So segregation of American cities, like what we see here in Baltimore, have played an important role in neighborhood economic development here in the 20th century and beyond, and patterns of investment that are associated with racial and economic segregation have implications for community health today. And some of the speakers this morning talk about that. Tanae mentioned, the segregation, the racial injustices. And so when we think about it, we typically think about it for lower income and minority women. But what you need to recognize is, because of segregation, white women tend to live in more diverse environments Black women tend to still live in segregated environments, even with more education, even with more socioeconomic status, because we're living where we can be comfortable. And so when we're living in neighborhoods that are disproportionately impacted by community violence, that's all of us of all socioeconomic levels. And so, yes, it impacts us more, but it doesn't mean that you shouldn't also talk to white women. So when we think about this, Black women specifically, coming back to it, we're more likely to live in these economically disadvantaged neighborhoods. We're more likely to be exposed to community violence during pregnancy, not just intimate partner violence, which is where people sometimes go first. We're more prone to elevated risk of preterm birth and low birth weight and all of those things that you guys are out there used to dealing with on a regular basis. But in utero exposure to community violence specifically has consequences for health and economic outcomes, not just for the mother, not just for the child during the time that they are in utero, but literally it contributes to disparities that that child may have throughout their life course. And so exposure to community violence, it plays a role in racial ethnic disparities, but it and pregnancy complications and gestational weight gain, all of those things that you talk about. But it also plays a role in how the mother internalizes stress and how they pass that on to their child throughout the life course. So community violence is very important. And why is that? Well, it's because it manifests itself in trauma. So when people live in communities where violence is pervasive, it impacts them in numerous ways. People may have heightened fears that harm could come at any time, right? Like you're jumpy all the time. And you experience the world as unsafe and terrifying. And usually, if you have one traumatic experience, you have that for a limited period of time. But we're talking about people who are experiencing pervasive, chronic, consistent trauma. So as a result, it's a constant trauma response. Now, the longer we live, the more likely we're going to experience trauma. And for some of us, even from the discussions this morning, for some of us, childbirth itself is a traumatic experience. It was mentioned in the introduction that I work with, do research with minor human trafficking victims. Well, guess what? Minor human trafficking victims grow up to be birthing women. They grow up to be birthing transgender people too. Okay? In fact, some of the minor human trafficking victims that I've worked with, they were forced to give birth to their trafficker's child as a way of control and coercion. Okay? So this is all interspersed. But one of the things, especially when I talk to women who have been victims of human trafficking, childbirth, when you have been a victim of human trafficking, it's like danger levels trauma. Because it brings back some of the things that you thought you dealt with, even if you've been out of the life for years. So trauma, it's not just for some of us a basic level thing, a one-time thing, but it's a complex thing. And being a woman, or whether you identify as a woman or whether you were born that way or however you want to talk about it, being a woman, period, comes with additional unique risk factors for complex trauma. We are more likely to experience sexual assault or abuse. We have a higher chance of experiencing child abuse from when we were children, domestic violence, or a loved one's sudden death. That's trauma too. We are more than twice as likely as men to experience post-traumatic stress disorder and other forms of complex trauma. And so the complex trauma, then, when you take it to birthing people, right, due to exposure to community violence, it may affect the risk of adverse birth outcomes. And you may see these as behavioral changes associated with the exposure that increase the risk factors for the preterm birth and intrauterine growth restrictions. Some women may react, tongue twister, for some reason. I have a problem with R's sometimes. But some of us may react to community violence by adopting coping behaviors that we as their professionals, their health providers, their doulas see as maladaptive. We're like, that's maladaptive behavior. You shouldn't do that. I really appreciated the fact that the mental health panel was before lunch, because it really ties in here. Some of what you see manifest is normal response to trauma. It just so happens that they're birthing at the time it happens, right? So you may see reduced physical activity, poor diet and nutrition, um, increased tobacco use, alcohol use, substance use. I'm coping, man. I'm coping with what's happening to me. I'm coping with the world around me. I saw a meme on social media this week that, one half of the world was talking about the Met Gala and the other half was on fire. Okay. For some of us, keying about the Met Gala, a place that we will never step foot in, is a way to take our minds off of the fact that the world is on fire. And that world is the larger world, but it's also the world right outside your door. So these health behaviors are linked to pregnancy complications. And you see them as like, they want to fight you, they want to run away from you, they freeze, they don't know what to do, or they overreact and they become you. I'm going to do everything exactly like the doctor said. I'm going to do everything exactly like the doula said. Well, what do you really want? I thought it was interesting when Tanae mentioned, like, do you believe in autonomy? Because the fawn response for some birthing people is actually them taking on what you're telling them to do more than what they actually want to do for their families and for themselves. And you've got to sit with that and realize, I don't want them to just do it because I say it. I want them to do it in a way that makes sense for them. So, one extreme manifestation of community violence that is experienced by a number of women, and I say a number of women because there are women who don't know that they were victims of it until they're out of it. And that's intimate partner violence. And intimate partner violence includes physical or sexual violence. It also includes stalking. It also includes, psychological mind games and gaslighting, but it has to happen by a current or a former intimate partner. And that's where I really want to sit with, is that the intimate partner part of it. Victims can be female, they can be male, they can be transgender, they can be outside of the binary, but most of them tend to identify as women in some way, shape, or form. And typically what we hear is people conflate domestic violence and intimate partner violence. And domestic violence and intimate partner violence are not exactly the same thing. Domestic violence includes other forms of violence. So that's where, the child abuse, the child maltreatment in the family, the other forms of coercion and psychological abuse that might be happening in a family comes into play. Intimate partner violence, it's your intimate partner. It's in that relationship with someone that you finally were vulnerable with. So imagine that. You let down that guard. And then that person exploited it in some way, shape, or form. That's the difference. Because when it's someone else outside, it's easier for you to say, oh, that's wrong. But when it's the person that you let down your guard for, you say, I'm wrong. You internalize it and you say, I did something wrong to let this person want to do this to me. How can I make it right? And that's how you see it's interesting, because when we talk about after the child is born and we talk about the attachment, right? Like that attachment period that we really want to have happen. Well, the problem with intimate partner violence is that we have that attachment, we've let down our guard, and we don't know how to unattach. Because no one teaches unattachment. Everyone teaches attachment. How do we come together? So there are 4 main types of intimate partner violence. And someone may experience one or all in the context of a relationship. Many times the warning signs are psychological and emotional abuse tactics way before the first physical or sexual encounter even occurs. beginning with the quarantine lockdowns, that in my opinion, some of them still need to happen, but that's another talk for another time. But beginning with the quarantine lockdowns themselves, IPV has increased and its impact has been exacerbated due to the pandemic, and it hasn't come down. So as everyone's been talking about the decrease in homicides, not just in Baltimore, but across the country, right? Homicides are down 19% across the country, 41% in Baltimore City as of Monday. Okay? IPV has not come down since it started creeping up during the pandemic. And so an examination of the PRAMS data from 2020, and the reason for that particular data is that data included an additional COVID-19 experiences questionnaire that year. And so when you look at that questionnaire, what we found is that pregnant women experienced increased sexual, emotional aggression in addition to physical aggression during the pandemic. So even if they weren't being physically abused, they were experiencing at least two others of the types of intimate partner violence. And so for us as women, you've got to think about, if someone's experiencing intimate partner violence, what does that mean? Right? So intimate partner violence has been linked to many serious health problems, both immediate and long-term. More often than recognized, gender-based violence of any kind can be fatal, as in the case of femicide, killing of women, and those usually occur after escalating bouts of violence. So think about what's happening in Israel and in Palestine right now, right? And the increased target that women have become. Think about it in the Congo. Think about it in Sudan. All of these times that women are being targeted as a way to get back at the men who are the players in these huge violent situations. But it happens every day, everywhere, even if there's not a war going on. And so other non-fatal problems that happen include injury, chronic pain syndromes, gastrointestinal disorders, and a range of mental health problems, which, like I said, that's why I'm very happy that was the panel before me. The often chronic nature of gender-based violence also increases a variety of negative behaviors, such as smoking and alcohol and drug abuse, just like community violence that I was telling you about, right? So IPV has severe reproductive health impacts, including gynecological problems, unintended pregnancies. And we've heard time and time again, more than 60%. And funny enough, I want to say 14 years ago or so, we used to say it was 73%. So 60% is an improvement in unintended pregnancies from 73%, but it's still a problem, right? Most of them are unintended, but it's also can be a result of intimate partner violence. But perhaps most gravely, intimate partner violence increases the risk of maternal mortality. Now, pregnancy is an extremely risky period for intimate partner violence because the abuse can start or intensify during the pregnancy. A partner who showed, or we thought showed, no signs prior to the person getting pregnant, all of a sudden, something about that pregnancy. I thought it was interesting when we said, maybe we need like dad doulas. And I actually know a couple of dad doulas. We need all of these things because pregnancy is hard on men just as hard as it is on women, not biologically, but mentally. Right? And so some of the violence that they beget during this period is because things that are triggered from their own childhood that they didn't resolve. Sometimes it's just because that's when they decided to start. Now I have her. Abuse during pregnancy poses direct risks, like the physical trauma and increased chronic illnesses. It increases your odds of having complications during pregnancy, even after controlling for other confounding factors. Some of these complications include vaginal bleeding, UTIs, early labor, premature rupture of membranes, all of these things. But there are also the indirect risks, like depression, like delay in seeking prenatal care, not letting them go to an appointment with you as a form of control. Women experiencing IPV during pregnancy are also more likely to deliver a preterm or low birth weight baby. So all of the work that we're doing could be undone in an intimate partner violence situation. The child themselves has an increase of infection, and then postpartum depression is higher among women who have experienced IPV during pregnancy, which may also impact the mother-child relationship, that attachment thing again. I'm afraid to attach to my child because I'm afraid of my abuser. Children born to women who experienced IPV during pregnancy also show signs of behavioral problems up to 42 months old. Not 6 weeks, not 6 months, 42 months of age. That child is experiencing behavioral problems. And think about what is happening during that birth to 42-month period, where they're supposed to be learning words at amazing rates, where they're supposed to learn how to engage and play and all of those things. So IPV is not just impacting the mother, but it's also impacting the child. Now, what are some of the risk factors, right? So first of all, victims can come from every age group, every religion, every ethnic racial group, every socioeconomic level, every educational background, every sexual orientation, gender identity. There is no discrimination. If you're going to end up being a victim, you're going to end up being a victim. But we need to recognize that. We need to recognize that there are some things that put birthing people at higher risk. So this includes being a teenager. This includes being a person of color, Black, Latina. It includes being unmarried. Even if you're unmarried with a doctoral degree, even if you're unmarried with a master's degree, right? But it also includes low socioeconomic income and low education. It includes women who delay their care or smoke during pregnancy. All of these women are at risk. Here in Maryland, women who experience IPV were more likely to have experienced multiple stressful factors in the year prior to delivery. Hear that, year prior to delivery, not 9 months, not the minute they got pregnant, the entire 12-month period prior to their delivery. So that preconception period that we're like, no one ever wants to talk about, we might want to talk about. So compared to women who did not experience intimate partner violence, those who did report 5 times the rate of homelessness and separation or divorce. 5 times. Socioeconomic status, issues of household income definitely took its toll with women who experienced IPV also experiencing twice the rate of their partner's job loss and 3 times the rate of unpaid bills. Okay, so let me get this straight. My partner's abusing me, stress, physical harm. I can't pay my bills, stress, right? Right, and now I gotta come to you and you're gonna tell me to do what? Buy vitamins, take this test, all these copays, more bills, more stress in a time when I should be happy. And I'm not. So the PRAMS 2020 data that I mentioned showed that during the height of the pandemic protocols, pregnant and postpartum women with any economic problems, any housing instability or any other family challenges had approximately a 2 to 4 time, depending on which of them, prevalence of reporting physical intimate partner violence during their pregnancy, or increased intimate partner violence compared with those who didn't have any of those stressors. And as the number of stressors increased, as I had more than one of those, my potential for experiencing physical intimate partner violence also increased. So, what do we do about that? I don't know. I do. I'll tell you in a minute. The other thing I want to point out, though, is some of these studies talked about arguing. How many of you have had an argument at any point in your life? Okay, right? Like seriously, right? How many of you argue with your husband or your partner in some way, shape, or form? I fussed at mine yesterday. Wait, I'm going to tell you this site because this is the room to say this. My husband had a doctor's appointment yesterday. So my entire family is military, right? My husband is a Marine. He went to the VA. My oldest is has already done 12 years and been out of the Navy for years. My daughter is in the Air Force, and then my baby is about to graduate from Morgan. And I told him, please don't join the military. I can't. But I digress. So my husband has a doctor's appointment yesterday at the VA. And he comes home afterwards and he says, the obstetrician said, and I went, but excuse me? He said, the obstetrician said, I said, oh, wait a minute. Who are you done got pregnant? He's like, what are you talking about? You know, I went to the obstetrician. I said, I did not know you went to the obstetrician. And then he's saying it, like he's saying it over and over and over. And then finally he looks at me and he goes, oh, optician. Like, and I'm like, neck rolling, everything is happening because arguments happen, right? But when you think about arguments when you're pregnant, right? And when your hormones are going and you want to, but women who argued with their husband or partner more than usual in the 12 months before delivery were actually more likely to have been victims of intimate partner violence during pregnancy than women who had not argued more than usual. The vulnerability of pregnancy in many of those cases led their partner to feel more comfortable physically abusing them when they argued. In the Maryland data supports that about 3 times the women who experienced intimate partner violence during pregnancy reported increased arguments in the year prior to delivery. So what does this all have to do with maternal mortality, right? Well, it's the primary driver for maternal mortality in the United States. Intimate partner violence during pregnancy is as common as gestational diabetes and preeclampsia. But yet, it's not on the list. Okay? 324,000 women each year. In fact, pregnant and recently pregnant women up to 1 year postpartum are more likely to be victims of homicide than to die of any other cause. Being pregnant or postpartum increases your risk of death from homicide by 35%. Women experiencing physical intimate partner violence have been found to be associated with lower attendance at postpartum visits. That 6-week visit, they miss them. That warm handoff is even more needed for them. The risk of murder remains high for up to 24 months postpartum for some women who have experienced intimate partner violence. 24 months. So there are 2 public health crises that are claiming the lives of Black women at an alarming rate. the issue of maternal deaths, pregnancy loss in general, and intimate partner violence. Because many survivors of intimate partner violence live at the intersection of physical and emotional and sexual violence, and then mix that with all of the other risks, we end up with Black women specifically being 55% of the pregnancy-associated homicides that occur here in the United States. So in Maryland, women are the victims in most IPV cases, with 92% of assaults being intimate partner violence related. Homicide is the leading cause of death in Maryland as well for pregnant and postpartum women, more than half of these being perpetrated by intimate partners. Yet, only about 7% of women here in Maryland report to us being physically abused by their current husbands or partners or former partners during their pregnancy. So there's a serious disconnect between reporting and the impact of intimate partner violence here in Maryland as it mirrors the US numbers. So what can we do? Screen everyone. Everyone. Y'all know that you're supposed to screen. People are supposed to, like, and we know, okay, I got to screen for this, I got to screen for that. And you go through and that 80-page document that everything is buried in, right? First of all, you're supposed to screen every person of reproductive age, period, point blank. Not just when they get pregnant. That 12 months before, they don't even know if they want a child yet. You're supposed to be screening everyone. We don't do that. And when we do screen, guess who we screen? We only screen Black and brown women. That obstetric racism that Tanae was mentioning, it's almost like it's the reverse. Like, you're hyper focused on, oh wait, I'm supposed to screen for intimate. Oh, she doesn't look like she'll be a victim, so I'm not going to screen her, but I'm going to screen the Black and brown ones. You know who that's killing? That's killing the white woman in Allegheny County, a county that is already a medical and behavioral health shortage area, who is traveling over an hour to get to you in the first place, and you're not screening her. And then she's going to travel an hour back to a remote location where she's going to be trapped with her abuser, and you didn't even notice. That's who it's hurting. So when we're supposed to screen, oops, what did I do? Jesus, Joseph, and Mary. Sorry about that. This is what happens when you have fat fingers. There we go. Okay. So in Maryland, we don't ask. United States, we don't ask. We actually seem to be disregarding screening everyone and just screening the people we think might be abused. Okay, so we're not screening the white woman in Allegheny County. We're not screening the woman with a doctoral degree who graduated from University of North Carolina and is now working at your actual hospital right next to you. We're not screening those. The other thing that you need to do, because there are all these items, these questionnaires for screening that exist, but you got to do this too. When you're screening, you have to ask about arguing. And you don't do the, well, do you argue with your partner? Because I asked you that and you all were like, yes. And I told you my own story. No, you got to ask them about arguing. And you got to say, well, has the fussing increased? Because when we ask, we have to ask it in a way that is culturally competent. So everyone argues. I argue with my boss. I argue with my parents. And I said parrot, P-A-R-R-O-T. That little thing runs my household. I have a parrot that tells us when he doesn't like the music that's playing on the radio. I argue with a lot of things in my house. But arguments increasing, it's the likelihood, it's a 25 times higher association with increased aggression even if it's not the physical IPV, before it gets to the physical IPV. And low disclosure rates of IPV have been found also because sometimes we don't see certain behaviors as abusive. There's a misconception of it only being that physical or sexual. So unwanted phone calls. Why is he calling me all the time? But you don't tell anybody. Well, maybe he wants to know about the baby, but instead he's yelling at you because you fed the baby McDonald's. You know, threats. And it may not be threats of physical harm. It may be threats that I'm gonna tell somebody about how you treat my child. Okay? Damage to personal property, breaking their things, throwing their things out the window, coercive control. All of those things may not be understood as intimate partner violence, but they are. And because healthy conflict is normal, there are misconceptions about that arguing being normal as well. And so disclosure happens because, well, that's normal. He's always done that. Oh, wait, that's a problem? That's not a healthy relationship? I didn't know that. I'm perpetuating a cycle I didn't even know existed. There's also how I view myself. I let this happen. How can I tell you that I let this happen? And so the stigma, the feeling of shame, the guilt, the embarrassment, all of that, when you screen everyone, it breaks down some of these misconceptions and barriers. I haven't had a uterus in more than a decade. You know what my doctor does every single time I walk in the door? When was your last menstrual period? Check, I haven't had a uterus in 12 years. But it's the same screening question. And we both have a laugh about it. She's like, yep, you're right, check. 12 years, I've had the same doctor and no uterus. So when you do these screening tools, ask about arguing. The other thing, for those of you who are working with the baby, put it in their chart. If you've screened and you're seeing something, because you're only seeing them, or you may not see them at that 6-week period, when you pass that child along, put it in the chart so that the pediatrician knows that it's happening and can ask about it in that screening. Because guess what? They may miss your follow-up visit, but they're not missing that first visit with the baby. It's all smiles. Oh, I get to take my baby to the doctor. Screen then. Pass that information along. So you have a role to play. It's important for you all as providers to respond to birthing people who are dealing with intimate partner violence. Responding to them is important for them and their families' overall health. And as you should be doing for any medical issue, provide competent, compassionate, confidential care and treatment. It is not your responsibility to solve the problem, by the way. There are so many other people who can do the solving. You've just got to identify it and give them the warm handoff to the person who can help. You should be focused on the care and safety of your patient. But since you are not the one to solve it, how else can you help? Well, first of all, you've got to think about who needs to be at the table. The first step is to build that infrastructure within the community. When we recognize that this is a public health problem, we see the potential to engage multiple stakeholders, hospital administrators, healthcare providers, but also federal, state, community agencies, researchers, legislators. Who else should be at the table to help you support survivors? Who should you be referring and providing that warm handoff to? Think about that. Who is in your circle of influence that you forgot to invite? And I say that because so I have a massage therapist who is a former labor and delivery nurse. Funny enough, one of her warm handoffs, like as a massage therapist now, is the plastic surgeon in the next building where she operates. The plastic surgeon saw the need for those plastic surgery patients to receive therapeutic massage after surgery and built this relationship. Was like, and they have this automatic handoff. All of her patients, their first visit is longer because they see the plastic surgeon and then they get a massage. An automatic, the plastic surgeon. First of all, tummy tuck would be nice. I can't afford it, but think about who is missing from your tables. Maybe it is a massage therapist. Chiropractors. When that was mentioned earlier, I was like, my chiropractor was my best friend from month 5 of pregnancy until about month 6 after. All of these people who may see things that you don't. So stakeholder engagement, authentic partnerships, these are all critical to addressing intimate partner violence. And so when you engage them, you've got to also recognize who's present, how can you build relationships with them? And it's more than inviting them to the table, albeit that's the necessary first step. In inviting them, you need to actually demonstrate a commitment to real partnership. Don't have me at the table and I'm sitting in the corner and you, oh, wait, you're here. What is it you do again? Don't do that. I've been in those rooms before too. Don't just invite us. Tell us what you need from us, and we can tell you what we can do and what we can't do, and we can work together. Because the bottom line is the birthing person. So this is just a quick sample policy, because if you are having an intimate partner violence program, you got to identify who the people are, what is the actual policy, what is your intent, and then what are you going to do? So if you're going to screen, you can't just screen and be done. You got to screen and figure out, okay, who else do I need to bring to the table? Who do I need to refer them to? How often am I doing this? Where am I referring them out to? Why am I even doing this? Am I doing this just because, oh, well, ACOG told me I need to screen? Or am I doing this because I actually want to equip all of my clinical staff members with the skills that they need to support our birthing people? Okay. And then think through the entire procedure. Screening and identifying me isn't enough. If you check a box that said, oh yeah, she's experiencing more arguing and some pushing and shoving, okay. And then you move on to, oh, but she has gestational diabetes. Let me send her to the nutritionist. Let's actually identify, then assess, then refer. Don't just do one. So my last point is really assist your clients. Ask them about intimate partner violence. Send them messages of support. If it's present, provide safety assessment and planning. Because you may not be able to say to them in that room. And I loved it when people were like, talk to the person in the room with them. What if the person in the room is my abuser? How do you provide me with that handoff in a safe way? Inform the patient of their options. I don't want a fluorescent green piece of paper when it comes to the violence stuff. For the mental health, yes, not for the violence. But also don't bury it. Don't bury it so far that I can't find the hotline number, because that's a problem too. Provide supportive documentation. You might not want to put this in a way that their ICD-9 code, if their abuser is the person who pays the medical bills, sees it. And then last, tell other healthcare service providers, y'all aren't the only ones in this fight. Go back and tell everyone else. And this is going to take collaboration between the system, between all of us and policymakers, as well as all stakeholders. So thank you very much. I don't know if there's time for questions. I've lost track of time completely. Yes. And I actually am a person with a hidden disability, so please use the microphone.
And I have a loud voice too. So in our institution, we are really addressing this and going in depth. And I can tell you, none of this is easy
No.
because it took us a year just to figure out a large clinic how to work this into our system, who's going to be responsible for it. We don't want to open the door and have nothing on the other side. So thank you so much for reminding us that is more than just screening involved. The other thing I wanted to just warn people about now, because we have an electronic patient record and people can have access to their notes. So you might want to be careful about what you put in a note if the abuser can get his hands on the note. It can view the, chart.
Especially if they're the one paying for your medical visit. Oh, there's one over there. And I can't read lips from a distance, so. it's really
I have a
hard.
virtual question.
Oh, okay, there we
What
are.
screening tool for IPV do you recommend home visiting nurses use? There seem to be a few to choose from. Which is the most culturally appropriate for non-English speakers from different backgrounds?
So ACOG and what is it, American Committee on Obstetrics and Gynecology and American Academy of Pediatrics have two really good ones, and they've been translated and normed in different languages. So I would go to those that have already been translated and normed. Oh wait, is that on?
I wanted to mention that we do screen our clients for IPD, but the thing is sometimes afterwards you feel helpless because it's not a lot of resources. Like if they want to leave the situation, there are limited housing resources and the abuser may be their only support person. So that's something to consider as well, because then they feel like I'm telling you this and you can't do anything for me.
So that goes back to that nonprofit industrial complex thing. There's so many of us out there that are doing this work. And that's one of the issues. It's an issue in our work with human trafficking as well, is even if a family member, right, isn't the abuser, you also might not be able to go there because the abuser has a way to get there. And so this is something that we all have to think about, like outside of the box. How do we do this? But I still would recommend reaching out there. I put some resources on the screen. I would recommend reaching out to some of these resources for that next level, because they all, including my own office, but we all have processes in place to help you at least help them devise a safety plan. Because that safety plan is the first thing, because it's more than what house or where do you put them in terms of a house, because you can put them in a hotel for 24 hours if you need to. You need to know what's the full plan. Like what's the next step? So you find them someplace to live that next day. What do they do the day after that? Your abuser knows where you work, where the kids go to school. Like it's a full plan. And we all have to work together to do that. So good question. Thank you. Yeah.
It is a.
Hi.
Oh, there we go.
Oh,
I was just wondering, playing the devil's advocate and don't mean to, but I was wondering, what do they do for the men? Do they have, if they're family, is there anything they do to the abuser to help him, or? I don't know. Do they work on that end, the abuser's end?
So I have the Muncie Visitation Center on the screen. Muncie being the Mayor's Office of Neighborhood Safety and Engagement here in Baltimore City. What they do, and I'm not talking about the screening or the actual abuse, but when there's a case of domestic violence and intimate partner violence, and the two parties can no longer be together, and that male still wants to be a part of their child or their family's lives, the visitation center is a place where that happens. It's a secure center where some of that happens. And they also have programs for the fathers. The other thing is that, I know this is a maternal health conference and talking more about female presenting people. We need men's health. And I said that we was in a meeting with myself, another medical doctor, and a male who's a doctor, a Black male. And we were like, yeah, so we're going to make sure that if we're doing this, we're going to also include men's health. And he goes, what's men's health? I was like, that's actually the problem. that men don't think about their own health. They go from being the like star football player or whatever in high school to being 45 years old on a CPAP machine with diabetes and high blood pressure, with nothing in between. And it's not because their health isn't important in between. It's because we have this misconception and this machismo in this country where men don't go to doctors until it's either too late or just late. And so, and so that goes for, and I'm saying men's health because mental and physical health are the same thing in my brain. I'm a public health trained psychologist. I don't separate the two. So we need men's health that's the whole thing, just like women's health is the whole thing. And that's the only way we're going to address that. Because the only way we're going to break the cycle of violence is by breaking the cycle of violence for both the perpetrators and the victims.